and welcome to another episode of Younger by the Minute. I'm one of your hosts, Jamie Spicer, and I'm always here with my co-host,
Jennifer Spicer. And I am so thrilled today. We have a special guest named Dr. David Saadat, who is a world-renowned triple board-certified plastic surgeon with over 20 years of experience in the facial plastics, aesthetics, and regenerative medicine fields. His expertise has made waves in the industry, and his passion for education is nothing short of inspiring. He's a surgeon who doesn't just operate, but he also shapes the future of aesthetic medicine. Dr. Saadat passionately educates fellow aesthetic providers, residents, and surgeons through his cutting-edge training institution. He's a sought-after speaker at prestigious panels and cadaver courses, sharing groundbreaking insights that push the boundaries of what's possible in the field. He is affiliated with some of the top medical schools and hospitals in California, including the renowned Los Angeles County, University of Southern California Medical Center, and Cedars-Sinai Medical Center. Dr. Saadat is on the forefront of surgical and non-surgical techniques. His commitment to knowledge and innovation makes him a superstar on the lectures circuit, where he captivates audiences with the latest advancements in the field. He also actively collaborates with fellow providers from around the globe, creating revolutionary techniques that others aspire to emulate. In today's episode, we'll dive deep into the transformative world of regenerative medicine treatments and the impact of GLP-1 medications and extreme weight loss on surgical outcomes. We will also highlight why continued education is essential for all aesthetic providers in this ever-evolving field. Lastly, we will go into regenerative aesthetics and what are some do's and don'ts in regarding to really getting biostimulation and making sure that you're safe for surgery. Welcome, Dr. Saadat.
welcome to the show.
Thank you, both Jamie and Jen, for inviting me. I'm excited to be on the show. Always nice to collaborate with you guys on things like that because great minds think alike. So looking forward.
100% agree, and being able to share our knowledge that we've learned and been blessed to learn from others is how we're actually going to change the industry and also make an impact.
Yeah, and the reason why I'm so excited, and as is Jamie, with you being on the show, is that you are a wealth of knowledge. And one thing that I must say from being a provider, in the perspective that I've gotten from you, you've always been there to support. You're always welcoming with questions. You always make time to talk. And that's not always the case when it's a mid-level provider talking to an MD. So I just want to thank you for giving everybody the respect that they deserve. And with that being said, you have a way of really capturing an audience and teaching and educating. You never make anybody feel less than, and you just do a really good job. And that's why I thought that you'd be a great host in having us on the show. And then also just going through some of the things that are really hot topic issues right now in regards to surgical outcomes and what is the best way going into that, or if somebody's thinking about that, and also debunking some of the myths that are out there in regards to procedures that you should or shouldn't do if you're thinking surgery.
Thank you.
I wanted to dive in first into the GLP-1s, aka tirzepatide, Mounjaro, Ozempic, semaglutide. And there is this controversy out there right now saying that it will ruin the SMAS. For those that don't know, that's the kind of the plane that you're lifting when you operate, correct?
Yes.
And that it will make the SMAS very thin and less desirable for surgical outcomes. Can you tell us how you feel about that?
I thought this was something that we only deal with in Beverly Hills, but apparently it's all over the world now, this GLP pandemic affecting everything. And so let me just explain what SMAS is. I think it makes a big difference. We don't really understand SMAS, by the way. So there is a tissue in the face, and that's a little bit deeper. So when you, let's say if you peel the face, what we call delaminate the face in layer by layer, the first layer is skin, the second layer is fat, the third layer more laterally, closer to the ear, is called SMAS, submuscular aponeurotic system. So this SMAS is just like a sheet that covers the entire face. And as you go up higher, it becomes a muscle in the forehead called platysma that raises the eyebrows. When you go lower, it becomes a muscle in the neck. In the forehead, it's called frontalis that raises the eyebrows. Sorry, it's late during the day. It goes to the neck, it becomes platysma, and that's the one that raises the chest skin and kind of moves the neck. This is a whole sheet that covers the entire face. And our understanding of what it does is really not clear. I think what SMAS does is it holds all the little muscles under it together. So when you animate, when you express, then you have this unique expression that mine is different than Jamie's, different than Jen's. So when I smile or raise my eyebrows or animate or get angry or get happy, this coordinated movement of these individual muscles are because the SMAS is protecting and sitting on top of all of them. At least that's my understanding. It just, in an artistic fashion, why the face does what it does. So now, when we started doing facelifting decades ago, we thought that it's the skin that kind of falls. And what we did was lifted the skin, meaning separated the skin from the underlying fat, pulled it. And then we got this look that everybody hates, right? And then we decided, oh my God, facelifting is horrible. Stay out of it. Then we decided that if you put too much tension on a tissue, then it doesn't look good. It looks pulled. That's surgical 101. Everybody knows that's the biggest principle in surgery, that you do not close a wound in tension, because when you close it in tension, it just doesn't look good. So we said, okay, if we do a deeper lifting, meaning that put a stitch through the third layer, which is the SMAS somewhere around here, if you put a stitch through it and do this, then the overlying skin doesn't need to be lifted as much. So what we ended up doing was we delaminated the skin. So we peeled it up like this, put a couple of stitches in the SMAS, so it lifted the deeper tissue, then put the skin back, and then cut the extra skin without pulling it and stitched it. It looked so much better because then it didn't look like it was pulled. Then over the years, we learned that when we express and animate, the face moves in different layers. That some layers move on top of the other layers. They're actually two different tissue. The skin, fat, and the SMAS with the muscles are one unit. The deeper tissue, which is the origin of the tiny little muscles, the deep fat compartment, and the bone, so the deeper tissues are one unit, and this is moving on top of the other one. So this movement that we have here has a plane that we call the gliding plane, and the gliding plane is under the SMAS, not on top of the SMAS. So layer 1, which is skin, layer 2, which is fat, layer 3, which is the SMAS, they all move together in one unit. And one of the biggest mistakes that we did back in the day in facelifting was separating these from each other instead of lifting them in one unit. So about 50 years ago, they started talking about how to go under the SMAS and do the lifting, do what we call a procedure called deep plane facelifting. You hear about that. So that's why we're going one layer deeper. So this deep plane facelifting came about that basically lifts the whole 3 layers at the same time. And it made a lot of sense. So this is the latest that we're doing. We're doing a deep plane facelifting. Then we realized that the face has a ligament here anchored that connects the lateral portion of the face down, and we have to release these ligaments so that the tissue is released. So we cut it, believe it or not, cut the ligaments and come all the way to the nasolabial fold marionette area. So then we get this, what's called extended deep plane facelifting, as opposed to the regular deep plane facelifting. And now what we're doing is we're not separating the skin and the fat and the muscle from each other. We just go quickly, lift a little bit of skin and go under the SMAS. So we're preserving the skin attachment. So we call it the latest 2024-25 is preservation extended deep plane facelifting. So that's what we're doing. Now, when you look at these 3 layers, it's skin, fat, and SMAS. They're very tightly connected because there's one unit. When you have any kind of rapid weight loss, and this has been proven not just because of GLP, at some point we were doing bariatric surgery, gastric bypass. People would go on some weird diets where they don't eat for a long time and they lose weight quickly, and they go on the other medications. And obviously the latest one being GLP, because of the rapid weight loss, we know that affects the skin. The skin becomes thinner, gets more lax. We know that we're losing the fat that's between the skin and the SMAS, the so-called SMAS, and we think that some of the fat is, even though it's in between, it goes into the SMAS, and then we think that the SMAS gets thinner. the point is that overall, all three of these get thinner. And when it's really thin, then you don't have a good tissue to grab and pull and lift. What you were saying earlier, Jen, is like a rubber band that initially, when it's like really nice and taut, then you have something that's very sturdy. But over time, when it becomes thin and lax, then even though you pull it, but it doesn't have that bounciness, that elasticity. So that's really what it's about. We've known this for a long time, and it's obvious that if you don't have a lot of good tissue support and fat and thickness and integrity, then when we're putting the stitches through to close and bring the face up, it's not holding as well.
Yeah. So
hopefully that kind of clarified it for the audience.
I thought that was really well explained, and actually I learned some things from it. And I'm gonna have to circle back to the line of ligaments and fixed fascia when I talk about threads and how aesthetics is forever evolving. But I think the biggest thing to take home is it's more about making sure that you don't lose weight too rapidly, and that when you are losing weight, you do it in a means that allows you not to be micronutrient deficient, because say you are a woman of a certain age and your hormones are already declining and now you're not eating, and then your collagen goes kaput, and then you're not going to have good skin or good dermal thickness. Or to your point, when anyone is too catabolic for too long, and that just means that they're starting to waste, and your body's always going to preserve fat because it thinks it's in starvation. So you're going to get a degradation of muscle. And what I do think that we do know about the SMAS is that it is a muscular layer. And I'll let Jamie speak more about the dangers of being too catabolic. But I think that's the biggest take home. It's you can utilize a GLP, you can utilize a diet, you can utilize all those things, but how you do it, the intention behind it, how fast is it happening, that is a big thing. When I worked for my old boss that was a plastic surgeon, she would wait to do any type of brachioplasty or anything until the patient had been 1 year out at the maintenance weight, because it takes time for that skin to come back and all of that.
And the thing I would probably add to that is, one thing that we have to admit too is majority of people are dehydrated. And if you want youthfulness in your skin, hydration is going to be one of the main things we would take a look at. But you pointed out some very key things. We forget of all the old diet fads, the quick fixes, that rapid weight loss. And we got to remember, a GLP is a peptide. The first peptide that came out to market was insulin. And when you look at the bodybuilding community, they've used insulin for a very long time. But they use it, and the big difference is they eat a lot of food. So it's not the GLP that's doing it, it's the starvation, it's the micronutrient, macronutrient deficiencies. And then the third one I added in is majority of people are dehydrated. Their skin's not even hydrated enough to begin with. So that's where I stand with the GLPs as that side, is we're putting the blame somewhere where it shouldn't be. And I think you did a really good of explaining of how it actually breaks down and relates to the skin and the tissue.
And I think I got technical with the facelift part of it, but obviously I'm not as versed when it comes to all those nutritional and exercise program. But what the term that comes to my mind, when exactly what you two were explaining, is the skinny fat. You don't want to become skinny fat. And what is skinny fat? Exactly what you explained. Dehydrated, malnourished, because you're not getting the good nutrients and the proteins, and you're not maintaining muscle, you're losing muscle mass. And I'm sorry, I think majority of people that have already been overweight in that situation, once they lose weight, obviously they haven't maintained or built muscle. Those are typically people that don't work out. So they lose the fat rapidly and they have no muscle. And like you were saying, with the athletes, the bodybuilders, as you said, they're on insulin. And the other thing, I was sitting next to someone on the plane, and he said he would eat so much. And then a couple of days before his program, he would go on diuretics to hydrate himself. So it's all of those together. Yeah. And in my mind, my simple mind is that, yes, I love GLPs. I think they're phenomenal to get a boost and start losing fat and losing weight. But it's not so much losing all the weight, it's losing weight very correctly and carefully. So yes, you want to lose the visceral fat, you want to lose the abdominal fat, but you don't want to lose the facial fat.
Correct.
The facial fat is good. That's why fillers are a multi-billion-dollar industry. injecting fillers to make the face fatter, right? Because we lose fat, and you don't want to lose the integrity of the skin and make it lax, and it loses the elasticity and make it dehydrated. So you want to lose the fat in selected area and keep the fat in selected area and build muscle and make sure you're not malnourished. All the elements, the macros, all of those need to be replaced. You just don't want to eat bad. I think that's what it is. You go on GLP-1, but eat well, eat correctly with people like yourself that you're an expert on that. Maybe get some nutritional supports like all the peptides and everything else you're talking about with a very good exercise program.
Yeah, the other side, what I would say is making sure that people aren't overdosing, because this is one of those peptides that more isn't better. Honestly, getting down to a very minimum amount if that's what needed, but that's what's slowing down the digestive tract. But also, it's not going to be the fix to people's poor dieting choices or the fact that they were probably the person that was only eating one meal a day to begin with. Yeah. And now this just enhanced it. So I think, as we're just saying, the blame isn't on the GLP like they're trying to say. If they looked at the skin, in my opinion, if they looked at skin and put it in the same way without the GLP, and that person was completely catabolic, starving themselves, overtraining and everything, I think you'd probably see the same I know you would see the same result in the skin, because as you pointed out with the bodybuilders, what do they use towards the end? They use a diuretic, they pull the water out of the subcutaneous, then we use salt to drive it into the muscle, but it gets that really thin skin look, so we look very vascular. But then what happens the next day after a show, we're hydrated, we're eating, and all of it comes right back. Yeah. It's called filling back out. You're all filled back out, you look somewhat normal, you're not hollowed out in the face, it comes right back.
I think it's easier for men and women to bounce back from that, because women already have thinner skin than men anyway. Our collagen is different. Jamie has done a lot more competitions than I have, and I've had to do a lot of work to get my skin density back up just from going up and down with weight loss, even if it was like a 15-pound shift. But the one thing that I think that we forget in this country is that everything works together. And we were talking about this before we started recording. We tend to segment everything. And I think we also forget that the skin is an organ, and our body's always going to take care of more important organs first. We only have 4 organs of excretion. You have your GI tract, your kidneys, your liver, all of that. And if your body's starting to get so stressed out, whether that be from extreme weight loss, lack of sleep, whatever it is, it's going to start to degrade the integrity of the outer appearance, and that's the skin. Yeah. And so I think that's the biggest thing. Like if somebody's thinking about longevity and wanting to look good or preparing for surgery at some point in their life, they have to take it from a holistic, full circle, full spectrum approach. And that includes adequate sleep, adequate nutrition, adequate micronutrients. All of that is going to help the tissue be healthy and help people get the outcomes that they want.
And you need to, nutrition, hydration is only going to augment the money that you're spending for those procedures. You're going to spend that kind of money on that, then it's like you don't go buy a Lamborghini and never maintain it.
Exactly.
If you're going to,
or better yet, you don't go buy a Lamborghini and put really cheap gasoline.
Correct. I use that analogy all the time in food. So it's like if you're going to do that, then you should at least augment it with proper nutrition, hydration, do everything so you get the best result out of it. That's the big thing.
I think again, I like to simplify things and like in my own, because when something is dumbed down, I can understand it. So I like to dumb it down for myself. So when I dumb it down, I feel like a lot of people that go on GLP-1 or GLPs in general, they're thinking that, okay, if I start taking this because I can't eat anymore and because it suppresses my appetite, so then I'm not going to eat as much, then I'm going to lose weight. And that's the wrong way of thinking about it. It's not like you're not eating as much. I think the way one needs to think about it is that if I go on those medications because it suppresses my appetite, then I can probably control my cravings and eat, for lack of a better term, shitty food and just focus on eating better food. You still got to eat, but you got to eat the right food, not the bad food, because now you don't have the craving, the mental, the psychological craving for sweets and pasta and pizza and stuff that we shouldn't be eating. And I think that's really the main thing the take-home message from going on any of these, whether it's GLP diets, whatever, all these phentermine. There's so many other ways of doing this. Even a gastric bypass, a surgical gastric bypass, you still got to eat, but you still eat the right stuff.
Yeah.
That's what I was actually going to ask you. I don't want to get into towing a line here, but I've always had a hard time really wrapping my head around how a gastric bypass surgery would be healthy for a patient, because I feel like they become so malnourished unless they're really diligent about making sure they drink nutrient-dense shakes and stuff like that. And I understand that certain people need it, and I'm not here to tell anybody what they should and shouldn't do. Just to me, it always seemed like it was being set up just in the same way. Like, no matter what, at the end of the day, don't starve yourself. Just eat, try to do it moderately, try to make the most out of what you're putting in your body, and then how you burn calories and how you get stress off the body. Because exercise isn't meant to always just, it's not for vanity. It's also for releasing endorphins and helping to produce testosterone and growth hormone, which is also going to help keep you young. And for women, weight-bearing exercise and helping prevent osteoporosis. There's a need for physical movement, and it doesn't always have to be viewed as a punishment or a way to make sure that you maintain a certain size or shape.
And going back to what you said about the gastric bypass or any of those bariatric surgeries, and so they're phenomenal procedures, just like GLP-1s, phenomenal, just like exercise, phenomenal. But this is a multifactorial situation. So weight management is not just physically not being able to eat as much, that's surgery, or suppressing your appetite, that's a GLP-1. It's all of them. It's mental, psychological, social, physical, how much food, the amount of food you eat, the correct way of eating, learning what to eat, movement, exercising, all of those come together in one big pile, and a collection of correct treatments would come, it will have the right outcome.
Yep.
And I think that's what most of us are missing. I'm guilty of that too. I go on diet, I do this, that, but sometimes maybe my exercise doesn't include, let's say, balancing or movement or stretching. Right. It's mainly focusing on weight management, lifting weights. So it's hard to do, but I think it takes a good regimented program to be able to apply all of those to our lifestyle. It's a lifestyle change. It's not a GLP-1. It's a lifestyle change.
Yeah, I think what we're saying here is it's the mindset shift the person has to make.
Yeah.
You can do any of those surgeries, you can do any of the GLPs, you can do any of the fat loss drugs, workouts, but if your mindset hasn't shifted and you continually go towards junk food, sugary food, stuff like that, and justifying that, I deserve to eat it, then none of them are going to work or get the outcome that you're looking for.
And I have to say something. I think one of the biggest problems, at least in this country, is that the food that's, not that I'm trying to get political in any way, but the food that's provided to us, the food that's readily available is not good.
No.
And
100% agree.
if you really think about a husband and wife with kids, that both the husband works, the wife works, the kids go to school, they come home, they're tired. In order to have a good meal and prepare a good meal, it's a lot of work.
Yep.
And what do? They don't have the time. They just stop by McDonald's or pizza and pick it up and bring it home. And unfortunately, that's what's readily available.
Correct.
And I think that's a big, huge problem in this country.
It's a huge.
I don't know how we're going to fix it, but it's a huge problem.
I agree. I absolutely agree with you.
It's a huge problem, and we've traveled out of the country and lost weight. The other thing that's a problem is the amount of the speed or velocity that we try to run in this country. Like you go to other countries, there's a stress level that comes down. And that's why the GLPs are also very effective and really good for longevity in the long run, especially with neuroprotective stuff, because it's helping to minimize that continuous release of blood glucose that is happening just from stress, even without food. But then you add the quality of food on top of it, or even the microplastics and all this stuff, it starts to compound. So we're all human, and some days are going to be better than others. I think it's just trying to be intentional with what's the desired outcome that I want and how am I going to get there, and just taking small steps and looking at it from a global perspective. Some days we don't eat that well. Some days we do. Some days we can't get our workouts in. Some days we can. And that brings me to the next phase of where I wanted to dig in a little bit, and that's regenerative aesthetics and what that means. It's like taking those small shifts and having a regimented plan where you can do biostimulatory agents. You can get your normal every 3-month toxin treatments, or you can do things with radiofrequency microneedling or all therapy, and really working and compounding your collagen and keeping a youthful appearance. In your opinion, do you feel like any of those procedures, whether it's Radius, Sculptra, Renuva, Threads, hinder the results of a facelift when going to operate?
Yeah, you hit the one of the most controversial topics that we have right now. I've been dealing with this for a few years now, and I think I reported this at a meeting about 6-7 years ago when I had someone who actually came in with a big, huge lump of Sculptra here, and I had to take it out, and I was showcasing it on a meeting. So to answer your question, yes, they do affect surgery. To answer your question, again, and they can hinder surgery, but a lot of times they don't hinder surgery. One of the biggest controversies and issues that we need to figure out is that why do some people have problems when they have those with surgery, and why the rest of them don't? We have a lot of individual opinions. A lot of my colleagues get on stage and talk about how horrible they are. They really affect the surgery negatively, this, that, and I'm sure you heard that. Everybody heard that. Then we have the reality is that if you really look at a facelift patient, and we're talking about facelifting in particular, if you look at a facelift patient, not a lot of people show up in the office and say, I have never, ever had anything done. I've never had Botox. I've never had fillers. I've never had Radius. I've never had Sculptra. I've never had radiofrequency. I've never had device, but I'm here to have a facelift. Majority of people, they go through this progression of at age 20, 30, 40, start doing some toxins, and then 30, 40, 50, they do some fillers and injectables and biostimulatory and devices and threads, because all of us, if you're normal, all of us want to delay this inevitable that everything sags and we need to lift it. And then the reality is not everybody ends up doing a facelift because of many reasons, because of the stigma that goes with it. Some people can't afford it. It's expensive. Some people's husbands or wives, they're like, absolutely no, I don't want you to go through any changes. So not everybody ends up getting a facelift. So does it really matter? Because what percentage of people end up getting a facelift? So that's another thing that comes up. So at some point, there was so much pressure that came to all of us that I basically did a little mini study. I took a survey of a group of only facelift surgeons. These are people that only do facelifting, not others. And we divide them in different categories. So there are about 100. And I sent a survey with all these questions. Does it affect surgery? Does it affect the tissue plane? If it does affect surgery, why does it affect surgery? How does it affect surgery? Does it affect the outcome? All of those questions. So unanimously, most of them said that when we see it in the tissue, it does affect surgery. Unanimously, most of them said that not everybody has it. Let's say I do 10 facelift and only maybe 1 out of 10 or 1 out of 20 have these effects that we're talking about. 19 out of 20 don't have these effects. But in the ones that have these effects, and they're in the wrong area of the face, which I'm going to explain in a second, then it makes the facelifting more difficult. Mm-hmm. So what does that mean? Remember we said, and that's why I started by saying that when we do the surgery, we lift layer number 1, 2, and 3, the skin, fat, and the SMAS from the deeper layer. So that's the plane, the gliding plane that we lift and release the ligaments to bring up. It happens that also in that layer right below us, there are these nerves called facial nerves. These are the nerves that innervate the muscles of the face. And when they activate, when they work, the muscles move and they have the movement of the face. And if these nerves by any chance get cut, damaged, then the muscles don't move, you have paralysis, you look like a stroke victim, it's a disaster. And as a facelift surgeon, when you're operating and you're in this, between this layer and that layer and trying to dissect, go through little by little, and if you can't, then you freak out because you say, oh shit, am I gonna cut the nerve, not cut the nerve, what's gonna happen? And some of these, and different things have different effects. So some of the biostimulators, for example, they make the tissue sticky. Mm-hmm. So if you think about a page, a book that you flip the pages nicely, and let's say you dump coffee on the book, and all of a sudden these pages are stuck to each other and you have a hard time opening the pages, that's how it feels when we're doing the surgery. Sometimes when the biostimulators are in the wrong layer, under the SMAS, on top of the muscle, on top of the facial nerve, they create this stickiness between the two planes. And as we're trying to separate them from each other, they're stuck. You can't separate them. And as a facelift surgeon, you're like, oh shit, what am I going to do? Do I continue? Do I back out? Do I do a half-ass surgery? Do I do more minimal surgery? And that's exactly what happens. So then we took that study and we dissected it down a little bit. We had a group of surgeons that were a lot more experienced, and we had a group of surgeons that were a lot more novice. We divided them into two. And the experienced surgeon said, yes, we do see this. We see this stickiness, but you know what? We just go through it. No problem. We see stickiness with scarring. We see stickiness with previous surgery, with previous trauma. Somebody had a skin cancer here and it's hard to dissect. This is life. That's how we do it. We just go through it and do it. And then some of the more novice surgeons said, if this happens, we back out. And we say, okay, forget it. We switch the surgery and we do the older style where we don't actually lift anymore. We just put stitches and do that. So that was the outcome. The problem that we couldn't get out of this study was that I couldn't tell the incidence of problems with these. What percentage of people that get these non-surgical things have an issue with facelifting? So our second part of the study is we're going to collect data from 50 consecutive facelift patients, where as they come in, we ask them, what have you done? What sort of procedures have you done? Document it really well. And then go to surgery and see what we see in surgery. Do we see anything or not see anything? And if we see something, what are the problems? Stickiness, difficulty dissecting, not understanding the tissue plane, more bleeding sometimes. When there's thread lifting, sometimes the thread go and sit in that plane and they look like a facial nerve. So you don't know if it's the thread or the facial nerve. So these are the issues. And we want to document that and see that if we do 50 consecutive patients, and hopefully all of them or majority of them have had something done, let's say if only 1 out of 50 had that problem, the incidence is very low. If 10 or 15 out of 50 had this problem, the incidence is really high, and report that. I've already done a few and I presented it at a few meetings. I'm going to present this in Houston actually. And a few that I've done have had multiple things, but as I was dissecting, there was no problems. I think at the end of the day, and I'm going to make it short because I talk a lot, obviously, at the end of the day, what it comes down to, if these treatments are done in the correct anatomical plane, meaning that they're right underneath the skin, especially for biostimulators, or deep on bone, and they're not in the plane of surgery between 3 and 4, underneath the SMAS, where we are afraid of the facial nerve, if they're not in the wrong plane, then it won't affect the facelift surgeon and it won't affect the facelift procedure and the ultimate outcome for the patient. If they're done in the wrong plane, then of course it affects it. So at the end of the day, listen, there are providers like you out there that do the procedures, and these procedures are not going away. They're increasing by number. There's multi-billion-dollar companies out there, and they have good results. These biostimulators, tissue regeneration is amazing, really good results. I use them all the time, before and after surgery, because I want to improve the thickness, the integrity of my skin and SMAS. So I need these procedures, but you got to do them correctly. So my goal, at least, has been, as someone who enjoys educating and doing this, to make sure that I am conveying what we're seeing in surgery, and our goal is okay, do it, continue doing it, but do it correctly in the right plane, because you get better outcome and you won't interfere with surgery.
I think you explained that very well. I actually don't think that you talk too much, because you hit it from all sides, where the patient and the provider, and that's who I'm hoping would listen to this, because it needs to touch both. The one thing about the industry that we're in is that there isn't a control on who holds the syringe in their hand. And I think that's one of the biggest issues that we have. I think that you're talking about the novice surgeon. There are novice injectors. I was one of them. I'm still continuing to learn. The cadaver courses that you host. I still think
I'm novice. Some days I'm like, what am I doing here? I need to learn.
Because medicine.
We were talking about ultrasound before this program. I need to learn how to use the ultrasound, because
I started thinking, would that help? Would that help if a surgeon were able to assess what's actually going on? How long ago did the patient have these procedures done? How much did the provider put in that patient? There's so many variables. Like you brought up, why does it happen to some patients? Is that patient immunocompromised? Now we're in the age of COVID where mast cell activation is happening. Like to me, if somebody had a big glob of Sculptra, I tend to lean like maybe the provider didn't fan it incorrectly. So I've even changed, after learning about all of this, I've changed the way that I do threads. I try to do as minimally invasive as possible procedure for maximum patient outcome. And I take it from a full spectrum approach. Like we're targeting the skin with energy-based devices done in a very safe way where the heat isn't too high. We're not overdoing it. We're just scratching the inflammatory response. Because when you talk about sticky, to me, that screams scar tissue collagen. There's an overproduction of the wrong type 3 collagen that's not remodeling and leveling itself out. And I have had to do biostimulation post-surgical patients, and it is really sticky. I can't get the cannula through it, so I can only imagine what kinds of messes you guys might have to go into. And so, yeah, I think you have to look at it from a variety of ways. I think patients need to make sure that they're really credentialing the provider that they're going to, making sure that they have the experience that they need to have. I don't think any new injector should really be using a biostimulatory agent until they've had understanding what that gliding plane is. There's a difference when you're going through septi and feeling it, or you're just ramming it in. You're creating harm. So I think that was a great way to put it. And it's more about how it's done, just like with the GLPs and how people want to lose weight versus what's being done.
I think you hit it right in the head too with where my first thought was going was, I'm not sure if a lot of people really think about having plastic surgery done. It's probably not at the forefront of their brain in their 30s and their 40s. Hey, I know I'm going to have a facelift in my 60s and 70s, so therefore I'm not going to do this stuff. No, they're trying to fix the immediate problem or trying to prevent stuff too, because it's preventative in their 20s, 30s, and 40s. And the likelihood, like you said, of that might happening. Some people can't afford it. Some people are afraid to do it. So maybe they did come across some money and they did have the change they want to do it. But I think that it's not going to stop. Like people are going to continue to do this. So we need to figure out how to come at it better. And Jen, you nailed it. And so did you. Make sure you're interviewing the people that are doing this work before, making sure you're getting qualified people to do it.
And I think I don't know if you agree with me or not, but I'm probably going to lean towards you do, but I'll let you speak for yourself. I do feel like that's the differentiator between why some doctors and surgeons are a little salty to providers that aren't, because you guys have to be board certified. You pay your dues when it comes to school. And I'm not saying that some of us don't take it seriously, because I know I do, and I know there are other people that do, and I know you know them as well. And I don't even know if it's conscious either, because here you are, you want to start injecting, and here comes in the rep. And I'm not trying to talk bad about anybody. I'm just talking about a gap in the industry that needs to be filled. Yeah. And they show you all these things and they're like, look at what it can do. And now you've made this very large investment financially and you have to start moving it. And I think there's just some gaps that need to be filled where we can really slow things down and really start to learn. And I think that's why I respect you so much and how you're taking time out of your own practice to help, even with tonight being on this podcast, but you do work really hard to help other providers learn how to be better injectors.
Yeah, thank you. And so do you. And I think you both are saying what I've been saying in the past few years, because as you said, as a doctor, you go through a college and then medical school, then you pass the boards, then you do a residency program, you pass the boards. During residency program, you have mentors that are watching you operate every single minute, then you pass the boards, then you do a fellowship under somebody's supervision, then you pass the boards, years and years. As a nurse, you go to college, then go to nursing school, then go to the hospital. They watch you how to put IVs, how to take notes, how to take care of a patient. As a PA, the same thing. As a nurse practitioner, the same thing. But as an aesthetic provider, we don't have that. Mm-mm. We do not have a residency fellowship program. We are at our infancy for the longest time, and hasn't moved. And I think some of us, but I hope I can help, and some of the more experienced and enthusiastic people that passionate people about this should get together and create a board. I'm a facial plastic surgeon, and we have a board of facial plastic surgery, and we have an academy of facial plastic surgery. And plastic surgery has it, dermatology has it, internal medicine has it. We need a board, we need an academy of aesthetic medicine, or whatever we want to call it, where you learn how to inject, you learn how to use devices, you learn how to improve the patient's aesthetic outcome, and under the supervision with training, with real training. Because right now, if you really look at it, and I'm saying that for the general population out there, if you really look at it, anyone, any nurse, any PA, any nurse practitioner, any internal medicine doctor, we have ER physicians, neurologists can come out and say, you know what, I'm tired of what I'm doing, I'm going to start injecting Botox and fillers. And the laws allowed them. That's the problem. The laws allowed them. And believe it or not, as a physician, once you finish medical school, you get a license called physician and surgeon, and you can practice anything you want. But we learned that the hospital won't let you, the surgery centers won't let you, the public won't let you, because we demand residency program, training, specialty, and board certification before we start doing that. Most normal people say, you know what, I'm not going to go to a plastic surgeon who's not board certified. Why would I do that? There's a reason. There's a reason why I did that. So I know we're not there yet, and I'm not trying to, everybody that does this, they have good intention, but eventually it's our responsibility to make sure that we have a program where people go and train properly. And when they come out, at least there's some standardification of how to pass a test, verbally, written, and physically, so you become competent in what you're doing. So we're telling the general masses, the population, that, you know what, this person that has gone through this training program, has passed these tests, has got this board certification, qualifies to be an injector, qualifies to be a surgeon, qualifies to be a device provider. I think that's what's missing.
I agree with you. I agree with you, because not only is it the injectables, but the devices, you can do a lot of harm with certain, especially energy-based devices. But we were talking about it the other day, there's something that you can't take away from experience. Like you talked, going back to the surgeons that didn't have as much experience, they would back off, which they should have, because they took an oath to do no harm and they were uncomfortable. Like, you should not proceed if you don't feel comfortable. But at the end of the day, the one experience teaches you so many things. You start to get that dexterity, you feel the tissue, all of that. There's something to be said about time spent in something, and that's what makes you a master of your craft. And then on top of it, you should never feel like you're ever there. Truly, at the end, you're always learning. Oh. But yeah, you hit the nail on the head with that, because the laws need to change. Otherwise, it's a misconception, and it actually does a disservice to the whole industry. It does a disservice to the patients. And I do agree with you. I know we have the CANS board certification, but there's limitations to that I know they're working on. But I also think that everybody by law needs to be equipped with what they need to fix whatever problem may arise. Otherwise, it's malpractice. You teach people how to cannulate the facial artery if, God forbid, something were to happen. Like, how many providers actually have what they need in their toolbox, or have somebody in their phone that can help to handle a patient issue? Yeah. And I think it's a big issue.
And I think, like you were saying, and we're saying the same thing, at some point, all of us were novice. When you graduate, you have no idea what the hell you're doing. And I think traditionally, at least in medicine, and I'm sure in a lot of other things, and I'm sure a lot of us do this, is that you don't go open up shop as soon as you graduate and say, I can do it. You always go and join someone who's more seasoned, someone older, a mentor. And then, as we say in medicine, you pay your dues. You pay your dues for years and years and years. You work under them, under their wings. They take you under their wings. And then if you get into trouble, they save your butt. And sometimes you don't know what you're doing. You go ask them. And that's why you do that. You go work with someone who's a little bit more experienced, just because of all this stuff. And ultimately, it's to protect the public.
Yes.
We need to protect the public. We cannot, and as an industry, as a specialty, because I like to call it a specialty, because eventually we become a specialty. As a specialty, we cannot afford mistakes, complications, because what it does, it's going to make us all look bad. If anyone has a complication, whether they're experienced, novice, whatever, whether they're nurse, doctor, whatever they are, all of us look bad, and we can't afford it.
There's a local surgeon in my area who doesn't really like the biostimulatory agents. And of course, there's a group of nurses that don't really do a lot of training. They all work as 1099 and they inject everywhere. And I'm not going to go into my thoughts on that. But of course, one of those nurses put radius in a patient's lips, then had to go to that surgeon. And I'm just like, oh my goodness, like this is exactly why. But it's weird. And I don't know if it's because I grew up doing a craft that I also had to apprentice in. And it sounds funny, but like growing up and showing dogs, I apprenticed my whole life to then try to be a professional. I also know that you've apprenticed and you had coaches your whole life, like playing sports. And there's just, that is okay. It's okay to make your way up, to climb the ladder, to pay your dues. And I think that's one thing that if there's providers listening to this, that they need to take home with them. You are continuously learning. The patients are always changing. You can have a protocol, but the patient's the variable. You don't know when someone's going to have a complication or not. You just have to figure out how to mitigate the risks and how to fix it.
It happens to the best of us. How nice would it have been that if that nurse that messed up, or could be let's say could be an ER physician, and went to the plastic surgeon or went to a nurse practitioner who's very seasoned, instead of making him feel bad, making him feel like shit and talking down, say, you know what, why don't we use this as an educational process? Let's talk about it. Maybe even get on, I don't know, now everybody gets on podcasts and Instagram. Let's get on Instagram, do a live and say, you know what, we did this and we realized that this is not the right thing to do. Let it be a teaching experience for the rest of us that radius doesn't go on the lips, for example.
Yeah, because they are.
Why can't we do that? Why can't? So that's the only way to learn.
Well, that's like what you were saying earlier. You know, when you do bring these products on, you're not really going to a class. And so if you have the right people getting the products in your hand, you might feel equipped to do the job.
Well, that's one thing, like I applaud Jen with what she did when she learned how to inject. Not only did the companies have their area reps that then teach, and so then everybody in that area is learning based on that instructor. And if that instructor isn't taught or isn't exactly, then everybody's learning the same mistakes per se. She went out and I think 3 or 4 different people we brought in from all over, top injectors and stuff like that, and learned how to inject from multiple different people. But I think that's also where these injectors need to be taking courses like what you're going to do down here at the Dallas show and stuff like that. They need to be going and doing this continuing stuff and continuing to learn, because like you said, just because you learn from one person, in my 24 years of personal training and nutrition, me starting out at the gym 13, I didn't learn everything from one person. I learned from multiple different people.
Yes.
And then I was able to compile all that information, and then I could segment out what I want. I agree with that. I didn't agree with that. I definitely, that was great, but that's the only way I continue to learn. Even sitting in on this, I'm learning. And that's what you have to do.
The other thing that you always do, when he would have a complicated competitor, and I was always one of them, he would then go to his peers and they would talk about it. Like they would have case study collaboration. And that's the thing that, like, I know I could call you if I had something come up. There's a whole slew of people, and I feel so blessed and fortunate. And I think you only make those connections when you get yourself out there to learn and you ask questions and you take that leap. So what do you feel like if you were to give anybody looking to get into the industry or already in the industry, what advice would you give them for education? Just, is there things that you specifically like? I loved the cadaver courses. That changed my mind, because as an injector, you're always going in blind, and you still are. Like, they're not like all of a sudden you take one and you know someone's anatomy, because it's variable. But I do the ultrasound for that. I do using those tools.
Yeah, I know. That's a very complex question, because it's not an easy thing. It's not like you can learn it with doing something. So first of all, I think if you decide to go into this field, you have to realize that there are not good, solid programs that teach you everything. So unfortunately, in 2025, where we are, you have to be actively and aggressively looking for training. And you have to be hungry for knowledge. You have to read articles, read good articles, not TikTok and Instagram. Those are not articles, like real peer-reviewed journal articles. You have to go to a lot of programs. You have to have friends where tell you what training programs are better than the others. Pick the good ones. one of the things that we're doing, because I'm working with a lot of companies now, and one of my goals is in working with a lot of companies, it's not so much, I'm a KOL and this and that. Yes, I've been there, done that. I'm over that. One of my goals is that I want to work with a lot of companies to see how we can select the good teachers, the good educators, and how we can hopefully get rid of the ones that are not good, because there's so many ones, Jamie was saying, so there's so many out there that are not that great. So we need to get rid of the ones that teach the wrong stuff and they're not that great, they're not great educators, and pick and choose. So we're doing that on our part. And I think as a new provider getting into this field, you need to figure out who are the good ones. Obviously you don't know, so you have to have friends like Jen and other people in the industry to do that. I think the most important thing that I think that one needs to do is to find a mentor that is trustworthy, and just go up to them and say, listen, again, for lack of a better term, simplistic, I'm here to pay my dues to become a good provider. Can you take me under your wings? What does it take for you to take me under your wings? I'll do whatever it takes. Yes, I need money, I need this, I need an income. Let's talk about the income. But what can I do to pay my dues? So for you to be my mentor and take me under your wings and teach me how to do this, and make sure I go to the right courses. I take several courses a year, and of course, you have to keep that in mind. There's cost, and you make sure you kind of budget for that, because that's just the way it is, and do that. And now honing it down, of course, I'm very biased. I think anatomy is the most important thing. And I think cadaver anatomy is incredible because, as I always say, as an injector, provider, whatever, you're blind because you cannot see what's underneath the skin. And the only way you can see what's underneath the skin is either you peel it off in surgery, or the second best is you do it in a cadaver lab. So I think that's really important. I think those ultrasound anatomy courses are incredible. And then almost everything else, you need to learn the didactics. You need to learn the science behind it. You need to learn the actual products. How do they work? What are the side effects? What happens if I mess up? How do I deal with it? You have to have an emergency protocol for everything. And let's say if something happens, what am I going to do? Yes, I need to call a friend. Who are my friends? Who do I have close to me that I can pick up the phone? Like Jen was saying, she can always pick up the phone and call me, or I can call her. But who am I going to call and say, listen, I messed up here. This doesn't look, can you help me?
Yeah.
That's one part of the emergency program. Have all those emergency protocol kits that we always talk about. So it's not an easy thing. And I don't think you can just start on your own. I think without a good mentor that they can take you under your wings, it's really difficult to get into it. Correct.
Yeah.
What do you guys think?
I love the fact you brought up anatomy, and it actually just triggered a response to me. Like when I mentor people at training, I literally have them go to Amazon and buy a book on the anatomy of exercise, because it breaks down exactly what muscle groups are being used in that exercise. And that's one thing always complimented me on was like, I knew how to pair exercises to get these workouts. I've never been so sore. I've done these exercises, but I've never done them in the order that you did it. And it's I really studied the anatomy of the body. I got to know it really well. So I think that was a great point, was you really need to understand anatomy. And I know at least I hear all the time when she's sitting there putting makeup on or getting ready to do this, she's always listening to something revolved around that.
Yeah, I think that's the biggest thing. Like I try to take as much in, and I'll take from it what I can, right? Like we're always going to get pearls. And then sometimes you need to listen to the same thing over and over again, because your brain can only expand so much at one time. So like the first cadaver course, was so high level for me. And so then it was like the next time. But I think that it's really making sure you take a full spectrum approach also. Like we're talking about it from a health perspective, but also from a learning perspective. When you're injecting, you always have to figure out, okay, what is the desired outcome I'm trying to get? And what's going on in this specific patient? So if you don't understand the anatomy, is it bone loss? Is it deep fat pads descending or deflating? Like what's going on and what am I trying to fix? And then do I have the rheology in the toolbox to get there? Or how am I going to get there? Or is this a surgical patient? Have I told them about surgery? Like all of that stuff. So I think anatomy is number one always, but also understanding how to get to that goal. So if you're looking at the science behind the products that you're using, and then I think another big gap that's missed is the bridging of aesthetics from a skincare perspective to aesthetics into an injectable perspective. And a lot of times we get these devices, and as providers, we're not really taught. I'm lucky enough to have been an esthetician first. So I had a really deep dive into the tissues of the skin first and really understanding how collagen and elastin and all of that works, which has then just helped me. But that's from my own experience. So I think just making sure that you always have somebody that you can look at and gaining as much education as possible. That was a long-winded answer, and I don't know if I got there, but I think just making sure you're staying well-rounded is really what I'm trying to say, because there are a lot of resources out there. It's just making that intention to go. I found the ultrasound thing that I sent you before, that was just on YouTube. You just look at what you're trying to learn, and then do your facts, get white paper studies, compare it, cross-reference everything.
I think one of the biggest problems is that, and I hate to put it this way, is that some people are just not good at this job. And I think it's very important to recognize that early on, that this is not for me. And I'm sorry, some people just suck at it. They're just not good at it. And let me tell you why. We don't think about it this way, but this is reality. When you do this kind of stuff, when you're a, internal medicine doctor, it's very simple. You look at the patient, you examine them, you look at the numbers of the labs, and then you decide what medicine to give. The blood pressure is high, you go up and down, up and down. There's science behind it that you control it. When it comes to what we do, it's bridging the right side of the brain and the left side of the brain. You have to understand the science very, very well. And then you have to have an artistic vision and that abstract vision of looking at somebody's face and say, how am I going to make this face better? And it's very artistic. There's no science behind it. And translating what I see in somebody's face or body, for that matter, that doesn't look good, into science. Anatomically, if this mid-face is flat, why? Is it because they're born this way? Is it because the way the forehead and the eye and the nose is? Is it they're all together the way they are? Did they lose weight? Is it because they're born with a small bone? So now translating that artistic view of the face into more of an anatomical problem, and then coming up with a scientific way of treating it to make it artistically look better. So bridging the left and right brain all the time with this, it makes it really difficult. And then on top of that, what makes it really difficult is that, especially when it comes to injectables, you have to have a very good hand-eye coordination. Your needle, your hand, the way you move, you have to be slick, you have to be very smooth. And then surgery is easier, because when we do surgery, the patient sleep. I don't have to think about the patient. I just do my thing. When you're injecting somebody next to the eye and the needle is coming towards they're freaking out. They're scared of the needle. And if you don't know how to manage that, and at the same time how to have a good hand-eye coordination and injecting it correctly, it's really hard to do. And I'm sorry, I've done a lot of trainings for a long time, and oftentimes I've walked out, I'm like, listen, this person should pick another career. Right. Sometimes you just don't have it in you. And it's good to recognize from the beginning. It's nothing bad. It's just recognizing that this is really difficult for me and I shouldn't be doing that. And I don't wish that on anybody. I hope all of you guys are good out there. But if it's not for you, don't do it, because it's very difficult.
Shoot, like when I was little, I wanted to be a singer, but I have a terrible voice. There's just like things that I have to understand about myself. But it is funny that you say that, because I have always had an artistic eye, and with showing dogs, you have to groom the dog based on the standards. So you're making certain parts of the hair stand in certain ways, or you're using dye to dye certain spots to change the shadow and the highlight, which is exactly what you look at when you look at a face. It's shadows and highlights, it's balance, and making that the whole face look more harmonious, and changing little details. And it's 2 millimeter details. It's little shifts. It's not, you don't have to blow it out of the water or anything like that, but and I don't know if it was from that or makeup or you're just God-given talents or whatever, but yes, it's like the artistic eye, and then making sure you have a good grasp on the didactic and the science behind it. Is what I'm going to use, what am I going to pick up? Is that going to get me the result that I want? And how am I going to layer all these treatments in? Because for me, the other big thing, you guys were talking about Lamborghinis with gas. If the nutrition and the skincare isn't right, if the hormones aren't right, 100%. All of it's going to not come out right.
Yeah. Yeah,
together.
I always use the analogy of a tattoo artist. I can give you a tattoo, but I'm going to tell you I'm not the guy you want given a tattoo because you're not going to know what the tattoo looks like. Because
You're right.
there's guys that can really bang them out and give phenomenal tattoos because they just have that artistic eye. They know how to do the shadowing. They know how to do everything, and that's the differentiator. And like you said, I think it's a compliment that you can be that honest because people do need to be that honest. This is not the right profession for you because we know what the end result is going to be. It's going to be the end result of that person now out there not injecting, and then it gives a bad reputation and everything else to the industry.
And there might be a place for that person. Like I have met some people that just understand the science. Maybe they should go work for some of the companies and be an educator that way. There is a place, but maybe it's not the hands-on place.
Yeah.
So the last question that I had for you is, on the other side, from a patient perspective, and this might be a loaded question because if we had the aesthetic board certification that we should, it would be helpful. But what should patients be looking for red flags, or how should a patient credential their surgeon or their aesthetic provider?
That, again, another really difficult question to answer because that's the $1 million question, right? Who do I go to? And I think when it comes to surgeons, a little bit easier because, as you said, we have the board certification. So at least that's the minimum. That's not even that. The minimum is board certification. And then after that, you have to make sure that person you're going to actually specializes in that particular procedure. Back in the day, we said a plastic surgeon can do anything. You can do footwork, body work, butt, breast, this. Now it was 2025. We all specialize in different things. And because of the ease of getting to different people. There are people that are facelift surgeons. There are people that are nose job surgeons. There are people that breast surgeons. And you don't want to go to a breast surgeon and have a nose job, and you don't want to go to a nose surgeon and have a breast job. So that's really important to make sure that at least that surgeon you're going to is the one that has a lot of experience, Jamie was saying, doing it over and over and over and over and over again. So you have a lot of experience and been around for a long time because that's what matters. So it's not just doing one, it's doing many. So you learn from your mistakes and you get better and better. And then the other thing is, as we said, the artistic eye is very, very, very important. There are patients and surgeons, for example, that they like a certain type of nose. And I'm sure you've seen this. If you get on TikTok, on Instagram, especially in other countries, there are noses that are like this and ski slope and pinched. And so, some surgeons do that all day. And they get patients that want to have that done all day. So your artistic vision needs to match the surgeon's artistic vision. And even if they do 100 nose jobs a month, and that's all they do, sometimes it's just not the kind of nose you like. So from a surgeon standpoint, it's a little bit easier. Now, from a provider standpoint, of course, you want to go to someone that has a legitimate office. They have a good reputation, not just because they're Instagram famous or TikTok famous. Maybe ask around, see if you've had patients and other people that have gone there, check the references, make sure that they actively participate in education and learning because that's really important. And then make sure they have good outcomes. Ask them right off the bat, is this something that you do all the time? Do you do a lot of fillers? Do you do a lot of devices? But you're right, it's very difficult. It's very difficult to select a provider, especially if they're not board certified and they don't have those bodies that allow you to check them. How do you suggest we do that?
Oh, I think you the exact same way. Like looking at, I think photography is huge. Testimonials are also really big. Just being able to see the work. And then I also think there is something to connection. You might not connect with that patient or the provider, and that's okay too, because they can always refer you out or ask other questions. But yeah, no, I do the exact same thing. I would suggest the exact same thing.
I even think adding what we had spoke about earlier, like how accessible are you if something happens? Yeah. If I have a problem, like how reachable are you? And if there is a problem, do you have a plan in place? And can I see that? But I think, like you said, interviewing them, making sure you're on the same page. I'll use the breast dog world as a good example. Some people go in and they want a mild one and they come out like looking like stripper blowing up, and this is not what I wanted. That's what I do. That's what I specialize in. That's not what I wanted. But I think even like in my world with nutrition and when I work with competitors, before and afters was exactly what drew the client, because what I produced as far as results is what people wanted. And so I think that's a big one. But definitely, I think asking them, how accessible are you? If there's a problem, is a big question. Someone should be asking.
I think that's huge. And then the other thing that I would say is I think it seems like the provider is very genuine and has a good understanding of their knowledge base when they do a full assessment and they really talk about everything, but without trying to sell everything. Like, it should be a long plan. It shouldn't be, we're going to put 10 syringes in your face and we're going to do 5 more Vias and all that. Like, you have to develop a relationship with that patient's anatomy too, and understand that patient's physiology to really get a maximum outcome. I think really getting a good plan, getting a good basis, and just, there'll be red flags if people want to know that.
Yeah. And I think, sorry, Jamie, I think when it comes to picking a surgeon, that yes, it is important to get along with them, accessibility and all that. It's a little bit easier because you do the surgery, you heal from it, and then you're done, you move on. But when it comes to a provider, it's a long-term relationship. You got to make sure that you get along with them, you like them, you identify with them. And it's both ways. It's not just the patient identifying with the provider, but the provider identifying with the patient. Because sometimes there are people that come in and I don't feel the connection.
Okay.
So if you don't feel the connection, it doesn't feel good. Sometimes it's hard to deliver good surgery or medicine in general because it just doesn't feel good. So sometimes it's nice to say, I'm not the right person for you, or vice versa. The patient would say, you know what, you don't seem to be the right provider for me. I'm going to interview other people. I think it's important to spend the time to find someone who's good for you before you commit in a long term and stay with them.
And that's exactly what I was going to bring up. Is the provider interviewing you?
Yeah.
You know, they asking you key critical questions, because I'm always and that's one thing I learned in the nutrition world was I had to start interviewing people to figure out they were going to be the right fit.
Yeah.
Because in all reality, with me being the provider, that's my work that's out there. And if those people aren't following the plan and now they're not happy with the result, they're not going to say, I didn't follow his plan. It didn't work. Yeah. They're going to blame it on me and saying, he doesn't know what he's doing. He didn't do this. He didn't do that. It's like, no, you were out eating cheeseburgers and drinking beer every weekend. That's why it didn't work. So it's like, from the person getting the work done, is that provider interviewing you? Are they asking key critical questions? Because that also, to me, if I'm being interviewed and asked, that means they're not just looking out to how much money can they make off me right now, and then I'm out the door and gone, and maybe I never come back.
And I think that's where the telltale, like having a good questionnaire and a good assessment is key, because if we have a patient that has body dysmorphia, and I'm guilty of that, and I have patients like that, but being able to tell, okay, do they have realizations? Like, are they looking out for my best interest? It does work. It's a symbiotic relationship both ways. Yeah. So to recap, you aren't against GLPs, you aren't against energy-based devices or regenerative fillers, biostimulators, and threads, but only if they're all done with the right intent, the right approach, and a more holistic approach in mind.
Absolutely.
Wonderful.
They're all good. They're all very good if they're done correctly, and they're all very bad, including surgery, if they're done incorrectly, including nutrition, including your exercise program. If you, like Jamie, if you do it the wrong way, you can easily injure someone.
100%.
And this happens all the time. So that comes with every job, every business. And I think I'm glad you summarized that. There are some things that we realize after a while that are not good. Yeah. Some things need to, for example, it took us a long time I give you a prime example. It took us a long time to realize that silicone injections are not good. We don't do them anymore. But in the 50s and 60s, 1950s and 60s, that was the only thing we had for injectables. So some things we just learned that it's not good. We don't do them anymore. And then we just need to know, don't go back to it.
Yeah, we just pivot. Or even from a skincare perspective, doing very caustic peels, like an uncontrolled TCA, or even too much, like going too deep with a microneedling device, all those things. Like in the beginning, you think it's going to be beneficial, but then you realize over time it's not. So you change. And that's where I think no matter who you are, no matter what field you're in, part of always making sure that you stay young is being curious and asking why. There's a mindset to make, in order to really look good on the outside, you have to feel good on the inside. You have to believe that you deserve to be of a less weight, or that you believed that you are attractive. Like, all of those things start with an inner understanding of we're never done. We're always learning. Stay hungry, stay curious, and just continue to do the best you can in life. I think that's the trick to it.
Yep.
I think full circle, coming back to what we started with GLP-1 for weight loss. We connected it to surgery, then we connected it to nutrition and connected it to exercising. I think it's in order to stay young and feel young and look young. It's not just looking young, but also feel young and stay young. You have to think about how you keep your mind young. So what are the things we're going to do to keep our mind and psychology, mental young? What are we going to do to make our look younger, which we know because we have all those nice devices and surgeries and injectables? And what are we going to do to keep our inside young? The health, the gut health, the skin, the nutrition, the exercises, sleep. You mentioned sleep, probably one of the most important things. We need all of those to look young, feel young, and stay young.
Yep.
Absolutely.
Yeah, you could be 40 and feel 60, and you could be 60 and feel 40.
Absolutely.
Yeah.
It is the mindset. It's the mindset. And I like how you spoke something into existence, like the aesthetic specialty. It's the power of thought, whether it's good or bad, is very much huge. Like, we can all have delivered a great result, but if that patient doesn't feel like that what they see is good, it doesn't really matter. At the end of the day, we're trying to help other people feel their best.
Yeah.
So I want to make sure that we put your website, and on your website, can people find not only how to book with you, but also how to do trainings with you?
Yeah, please. Yes, that would be great.
Perfect.
Thank you so much. I know this has a nice, robust episode to it. I know you got done with working today. Thank you for taking the time to do this with us, and it's really much appreciated.
Yep. I really look forward to seeing you down in Texas.
Houston.
Yeah, but what is it? Yeah, about a month or so. Yeah, a month and a half, I think.
Yeah.
It's not too long. So I'll see you guys there.
Perfect. We appreciate your time tonight. And with that, I'm Jamie. I'm out.
Thank you, Dr. Saadat. Make sure you stay on.
Thank you, everybody, too. Stay young and healthy.
Yes. Bye-bye.
Bye, guys.